The delegates and I'm the chairperson of the next session, so okay. Right. So let us organize ourselves, and the delegates who want to attend the OPTOS session, I think the ladies can. We saw a lot of OPTOS photographs in the presentation. So please stand by for this OPTOS session. It will be a very good one. So Dr. Subhadra is here, and Chaitra, who else?
So we'll call everyone on stage. Welcome everyone to the Nikon-OPTOS Utility of Optos Symposium. We're going to be discussing image in clinical practice and disease management. We have excellent speakers on here and as panelists as well. First up is Dr. Debashish Bhattacharya. He's going to be talking to us on his personal experience. I'll also invite the other panelists on stage, please. Can we have Dr. Rajiv Raman, Dr. Vatsal Parekh, Dr. Sadda, and Dr. Subhadra. Ma'am. Right, so we'll begin off the session. I will be giving a brief about OPTOS and its utility, followed by Dr. Debashish on his experience. And then we'll take forward all the talks. At the end of the session, we also have the release of the OPTOS atlas that has been made very beautifully with Dr. Jalali giving us an introduction. Just before that, we have a very interesting 3 to 4 minute quiz for which there are attractive prizes. So I request all of you to please participate. So can I have my slides? So I'm going to be briefly covering OPTOS utility in disease management. I have no financial disclosures. So this is an overview of how the posterior pole looks, what is wide field, what is ultra-wide field. Most of you all know what they are, but what you need to know with ultra-wide field is that with a single capture view of the retina, you get up to the far periphery in all 4 quadrants anterior to the vortex vein. So that's your ultra-wide field, which is about 200 degrees, and the pan-retinal is one which gives you 360 degrees aura to aura view. So we have come very far from the montages that we used to do with taking small images and putting them all together, and you can see how poorly it demonstrates as against a full view. So we've seen a good evolution of retinal imaging. We've had wide field, we've had ultra wide field, we've had the red cam for pediatric imaging, and a whole lot. But today I'll be speaking particularly about the OPTOS, which is currently the system that gives you with one capture 200 degree view. So to give you a quick perspective, this is a slit lamp examination. This is the 90 degree lens, 90 diopter lens that we use, and this is the image that we get. Now go on to a 30 degree IDO. This is 45 degree of your fundus camera. This is your wide field of 100. Some have this where they do a montage of 2, and it looks ultra field, but it's a montage of 2 images. And then finally you have the Optomap ultra wide field with one image itself, 200 degree. So again, just to give you a quick perspective, 45 degree here, what you can see even on clinical examination, and that's your full view. So OPTOS ultra-wide field gives you 200 degree. It scans at a point posterior to the iris plane, and that's the virtual point. What we also use is a green laser channel to visualize the sensory retina and pigment epithelium, and the red laser channel for deeper ocular structures. So multimodal imaging is also possible. You have autofluorescence, you have FA, you have ICG. Just showing you some beautiful images. This is of the multifocal choroiditis, RP here, choroidal melanoma. These are all some beautiful slides which go on to demonstrate that how it's not only a good diagnostic or documentation tool, but extremely good as an educative tool as well to a patient. Because this is a patient who came with a massive hemorrhage here in the posterior pole, and I kept a close watch on him as we kept doing the laser, and you can see how it's progressing the disease. It became very easy for me to explain to that patient that he's eventually going to need surgery after giving him a waiting period, and this is post-op. Again, patient knows how it was before, how it was during and after surgery, and he appreciates the efforts that we have have put as well. This is again a patient with CRVO. You can show the entire extent of the disease. Patient thinks there are just 1 or 2 hemorrhagic spots. What's the big deal? But here's a tool where you can use it. This is hypertensive choroidopathy, very rarely seen, but we could well document it because it was well beyond the posterior pole itself. This is a sequelae of syphilitic panuveitis. You see a VPT here on closer examination there. Again, beautifully shown. This is idiopathic retinal vasculitis, again pre here and post laser. You can see good stabilization of the disease. Serpiginous like choroiditis. Our uvea ocular inflammation department is super thrilled with this device. And these are, post vitritis multiple HSTs that you can see a retinal detachment here, a closer view of the slit-like tear, so you can explain to the patient that this was the pathology. Atrophic holes. This is a peripheral PCV or PHCR, you can call it. Again, some more, we always tend to think that, posterior pole disease it is, but here it's there in the periphery also. Immune thrombocytopenia, just showing a couple of images that we were able to demonstrate here. This is a patient with VHL, and we counted, I think, at least 21 to 22 tumors across, and this was a one-eyed patient. When we finally had to take this patient up for surgery, the parents understood because it was a very young patient as to the severity of the condition. Here again, sphenoid ridge meningioma, METS, so beautiful demonstrated here. Left breast carcinoma here, a subretinal mass that you can see, angioma with a feeder vessel there. So this was the first ever paper that used the flying baby position to show that Optos can actually help us image even infants. And Dr. Jalali is going to show us how much more she's been able to do with this device now. This is the first ever, and now we have much more advanced devices. And these are some of the other pediatric conditions that we were able to image. And this is some congenital anomaly that we saw in a pediatric patient. Some more here. So this is some interesting optic nerve avulsion. So literature, yes, does show that beyond the ETDRS, we are able to document more peripheral diabetic retinopathy, which is probably has quite a bearing on our population. And even non-perfusion can be a predictor of the extent of the edema and the treatment response. I have had the fortune to be able to work with Dr. Sadda since the last decade, and we've been able to publish a lot of papers which have shown that, we can achieve a lot more with wide field imaging. So yes, 100% faster capture, 97% of AMD were found to have peripheral changes, 81% reduction in ungradable images, even on telemedicine screening, 76 more abnormal peripheral findings found, 66 pathology found beyond the 60 degrees, 62 more peripheral non-perfusion on angiography, and it has been able to change patient management as far as we've seen it with imaging. So yes, documentation and follow-up is essential. This helps in education. Non-mydriatic pupils, extremely useful tool. Non-cooperative pediatric, confirmation of peripheral pathology. It has a fast learning curve. Screening programs definitely helpful, and presentation and publications, like I just showed you, and in the previous session, we were able to show fantastic images. I thank my department. Thank you so much. I invite you all to our Rishi symposium that's going to happen, and we'll be able to show a lot more during this symposium because it's primarily focusing on imaging itself. Right, so we'll have Dr. Debashish speaking to us about his experience, and then we'll go forward with the next talks. Thank you so much.
Thank you, Chitra. Well, my experience would be more around not the intricacies of wide field imaging. Can we have the projection, please? Yeah, thank you. We were the first users of Optos. So essentially, thanks to this gentleman, Douglas Anderson, whose child went blind in an eye, and he was emotionally drifted. He's an engineer from Scotland, and so he took upon himself and decided, conceived these wonderful optics where you have a virtual point in front of the pupil, which actually scans the entire retina. So his idea was kind of seeing peripheral lesions and treating them early so that retinal detachments don't happen at the first place. And we bought the first Optos back in 2012. And so generally we throw Optos to everybody. Our technician there, Pratap, is there. He's helping us in conducting the halls. All myopics, all patients undergoing surgery, all myopics every 6 months after surgery, all flashes and floaters. So you get a whole lot of patients to do ultra-wide field imaging, and we do it at 300 rupees. What in dollar terms? $4 maybe. So if you have 500 patients OP, you can get 50 cases a day, 250 days, 300 rupees. That's almost recovers half the cost of the machine. So that's the financial part which I have to look to, and then it's happy, seeing and finding lesions and treating them. So the other thing is, when you find more lesions and you can show them to your patients like this, you can actually treat them. So there was a 70% increase in prophylactic laser treatments following our Optos acquisition. And I'll break up. We currently have 7 Optos. So starting with the 212 1DX, which still works, but now we put it off. So that required helium gas, but now with the Daytonas coming in, we acquired 2 machines in 2014, then 3 Daytonas in 2018, and now very recently we bought a California for the angiography part. So essentially, as our 500 patient centers went on increasing, we kept on buying an Optos, allowing the retina specialists not to bend their backs and have back problems. So that was the whole idea. And so we do 45,000 Optos every year, and that recovers us 1.32 crores every year. So I think it's also revenue generating at the same time at such low cost. And now we are enjoying these and finding out these lesions, but I'm nothing close to a retina specialist, so I won't be talking on all this. We have a beautiful panel to talk on all this. Thank you very much. We just wanted to post a concept of how centers which are busy can use Optos for a better advantage. Thank you.
Thank you so much, sir. That was fantastic, and coming from someone who runs these chain of hospital catering to a large population, and I think a lot are even myopes. I think this is a fantastic tool to not only document and to further manage these patients. Next up, we'll have Dr. Rajiv. While he connects to his presentation, I'll give you a brief introduction. He's a senior consultant at Shankar Nethralaya, Chennai. He also works very closely with the Department of Medical Science and Technology, IIT Chennai. He's finished his training in retina after his MS and DND from Shankar Nethralaya itself, and he's been there since then. He's also finished his FRCS, and he's done a lot of community work based on retinal changes such as diabetic retinopathy. So I think he's the best person to tell us about imaging, especially for retinal vascular diseases. Over to you, Rajiv.
Thanks, and thanks Optos for organizing this session. Next 8 minutes, I'll be talking on the ultra-wide field imaging in retinal vascular diseases, and I'll be mainly concentrating on diabetic retinopathy and retinal vein occlusion. So as we have seen in the previous, Chaitra has told us that definitely the more area of the retina you see, you can identify more lesions. And in diabetic retinopathy, 10% cases, the severity scale of diabetic retinopathy will change if you consider these peripheral lesions alone also. And this was one of the work which we had done with Dr. Sadda and all the institutes. We have Chaitra here, where we tried looking at that. We knew that a third lesions are PPL. We knew the numbers from the Western data. We never knew what happens in Indian population. Even in India, a third of diabetic retinopathy has PPL, the predominantly peripheral lesions. And we also found that mainly it's in the temporal quadrants. We had this very good paper which came out by Dr. Lord Paul Ailolo group, which suggested at that time that if you have this presence of predominantly peripheral lesions, these are the lesions which these patients have 4 times more risk of progression to proliferative disease. And definitely everybody was keen, and there was more use of these peripheral lesions identification using wide field cameras. We tried comparing whether you need a more resolution or you need a wider view, and we compared 2 of the wide field cameras and tried looking at the quality of the image to identify the posterior lesions versus peripheral lesions. And what we found that yes, both are equally important as far as diabetic retinopathy is concerned, and Optos, which was one of the camera which we had used, definitely overscores looking at these peripheral lesions. We also wanted this was another work that as a clinician, we don't always have grading center or reading center who grades these images. What happens among the clinicians, so we had senior retina specialists grading these images, and we found for diabetic retinopathy, early diseases, early stage of the disease, mild and moderate, about 15% cases, there is a disagreement as far as grading diabetic retinopathy is concerned whenever you use a wide field image. And traditionally, we also knew from long time that in ocular ischemic syndrome, we have these peripheral hemorrhages, mid-peripheral and peripheral hemorrhages. So is there any correlation of these peripheral hemorrhages with systemic disease? This was a work which we had done with Dr. Giridhar, and we tried looking at can we correlate with systemic features these PPL lesions, and we did find that those who had peripheral hemorrhages in diabetic retinopathy, they had more prevalence of coronary artery disease. And this is again a work with Dr. Sadda. We had these images, wide field images. We tried correlating, is it correlating anyway from the posterior pole ischemia? And the answer was no. So the eyes with PPL, they didn't have worse macular perfusion. This was presented in ARVO, and soon I think we'll be seeing this in publication too. And definitely we use Optos to precisely target panretinal photocoagulation if you are having targeted PRP. And many times we want to assess the adequacy of panretinal photocoagulation to assess which areas you want to cover more, do more fill-in. Optos definitely is a ready tool. And then this paper came up, the DRCR-NET protocol AA, where they found that the worsening was not related to the color fundus peripheral lesion, but with the fundus fluorescein angiogram, PPL. And they had 1.7-fold times more risk of disease worsening in 4 years. And they said that fundus photography cannot be replaced because 36% cases, there was a difference in grading between the fundus photo and the fluorescein angiogram, predominantly peripheral lesion, and it was a non-perfusion area which was important lesion as far as FAPPLs were concerned in diabetic retinopathy. We also tried looking at our data set to see that how many of these lesions are beyond 7 field. A very quick study, about 61 eyes we looked, and we also found a similar thing. There are nearly equal lesions on fundus fluorescein angiogram on 7 field versus the wide field, predominantly peripheral lesion, and CNP areas being the most important lesion. That makes sense now to quantify these ischemic thing, and probably measuring ischemic index would be one way, which is adding the surface area of non-perfused area, dividing it with surface area of the total fundus, multiplying by 100. And there are studies which have shown it correlates with severity, the progression, risk of neovascularization, treatment response, and even there are studies showing that it correlates with visual prognosis. It's difficult and very erratic, and the problem have been that it's difficult to reproduce in clinical practice, especially because in diabetic retinopathy you have these patchy non-perfusion. And if you look at reproducibility across various diseases, the least is in branched retinal veil occlusion, where we know there's a definitive segment which is ischemia, intermediate in CRVO, and the most variations occur in diabetic retinopathy. You can see these patchy areas of ischemia. Definitely the chances of reproducibility between the same patient will be less. Is there any better way we can measure these non-perfusion areas? People have used grids, And the grids were a problem because these grids, especially, there was a problem of peripheral warping. However, the newer Optos machines, California has got a Pro View, which compensates for this peripheral warping. You don't need to use additional software, and you can use these grids to measure the area of non-perfusion. I'll end with one of the marker which we have the person who has described this, Dr. Sadda here, who described this novel biomarker of RVBA, the retinal vascular bed area. Again, one of the marker which you can identify on a wide field angiogram. It represents the total surface area of arteries and veins. It's an indicator of angiogenesis, but not non-perfusion, and it delineates the larger and medium caliber vessels. And there were studies which showed correlation of RVBA with a more severity of retinopathy. Higher RVBA was associated with proliferative disease. Also, there were studies which Dr. Sadda led to identify what happens after anti-VEGF, and there was reduction in RVBA in PDR which were treated with anti-VEGF either monthly or 3 monthly, and monthly injection had more reduction in RVBA, again suggesting that probably RVBA could be a novel biomarker to monitor the changes, to look at the efficacy of retinal vascular changes after anti-VEGF if you are planning to use it in proliferative diabetic retinopathy. I'll share some of the examples. We had already seen a lot of these examples where no Optos or California shows importance, and this you have proliferative diabetic retinopathy. Do a wide field, you can see how extensive the disease has been. This was a very interesting kid who came with this type of exudation. Just last slide. And this was the other eye. Looks more like, the first thought was probably we are dealing with FEVR. You zoom in, you can see this bicycle wheel pattern and the macula. We did a ERG. It was more of a retinoschisis, and there are reports describing severe coats-like response even in retinoschisis. And when I looked at his brother, who also had decreased vision, and how beautifully you can see with this angiogram that this is not a FEVR case. Clinically, the moment I looked, it looked like we are dealing with a FEVR. On Optos, an angiogram, we could definitely delineate. This is the other eye. Thank you very much.
Thank you, Rajiv. Fantastic talk. Can I request Dr. Vatsal to connect? And in the meanwhile, Dr. Sadda, would you have some more insights into this? Because a lot of this work, you have really initiated. Yeah. So if you could just, because I think your topic doesn't really touch on this. So if you would like to tell us certain new insights.
First of all, I think Dr. Rajiv gave a great talk, really great overview of what we've learned about the importance of these peripheral findings, right? That they have prognostic value in various diseases. I think Dr. Rajiv really spoke, I think, beautifully about in diabetic retinopathy, these peripheral lesions, these areas of peripheral non-perfusion, they make a big difference. I mean, the fact that for so many decades we've been staging the disease using mainly the posterior pole or the 7 standard fields really highlights what we've been missing. So I think it was really an excellent presentation.
Yes, I remember though that this work has been ongoing since I think over a decade. And when I went and worked with him I think 10 years back, I remember sitting and annotating each of those peripheral lesions, in early diabetics. And we've actually managed to even create a model which predicts whether this disease has progressed or not. I think there's some fantastic work going on with Widefield. Next, we'll have Dr. Vatsal Parekh. He's a VR surgeon of repute. All of us know him very, very well. He's again trained at SN, and he's won several awards, and he's one of the few in the country who's actually been using one of the most advanced Optos, that is the Silverstone, the first in the country to have used it.
Yes.
So he's going to share some experience with us. Over to you.
So what I am going to do is to take you through clinical cases, what I've been doing in my clinical practice over the last 3 years since I was fortunate to acquire this machine. Now, this is a Swapsos OCT. Basically, it's ultra-wide field, and you can go anywhere in retina with the OCT with little trick. And I'll show you some of the cases. Now, this is the first case, which is a slit lamp photograph. There's a dense corneal opacity, slit lamp biomicroscopy with 6 TD lens. You just see the optic disc, but with the Optos, you can take a posterior pole reasonably well. And because of the Schweppes OCT, you can see the macula also reasonably well. Now, I think the key what I have found is the possibility of doing OCT because it Schweppes in gas-filled eye. To the left is the pre-op macular hole, and the next is 3 hours post-op macular hole OCT. You feel that the hole is closed, and 24 hours later, you are sure that the hole is closed, and 7 weeks later, like any other regular OCT, you can see it's closed. So probably we are successful in doing first day OCT in about 50% of patients, where we can make out. Only problem is that since there's no view clear, your alignment through the macular hole, you have to spend time to see it, Now, we would not have seen this lattice degeneration except in textbooks, and this is beyond equator, and you can see that there's peripheral thinning of the retina, vitreous adhesions, and this is because of the Schweppes OCT. You can see the lattice being dissected so well. In vitro study, you can see the lattice is so well, and probably I'll show you some of the variants what we see in lattice, what compared to what we read in textbooks. Now this is a lattice which has been captured here. This is a magnified view, and instead of normal thinning of retina, what we read in textbooks, there is retinoschisis in this patient, So I think if we do more of this, we will understand pathology much more than what it is there. Now this is another area of lattice with retinal hole, if you see here. And this is the OCT through that, and you can see the demonstrate the hole here. Now one would wonder that why do you need such expensive instrument when you can do this with the scleral depression, Yes, you can do with scleral depression, but there are some patients which are lesions which are sort of posterior to the vortex vein, and you may not be able to reach them with scleral depression, and means there this technology will help you to delineate the pathology whether it's whole or not. This is another patient where this is a lattice, and you can see the abnormal vitreoretinal adhesion here well, You can see the entire vitreoretinal anatomy, that there is vitreous traction, and you can see the cube moving there. So this is all possible these days. Now this is white without pressure. Again, this looks relatively normal. The retina in periphery is thin. This is another patient with white without pressure here, but this was retinoschisis. So now this is another white without pressure, and you see the retina shows retinoschisis there. So probably I was thinking because of the retinoschisis, that appearance of white without pressure is there, because the light is not reflected. Just as in a shallow detachment, the color is altered. This is the reason why this color is like this. Now, this is again a retinal hole with subclinical detachment above, and retinal hole with which is lasered there. Now again, these are the laser marks, what you see on the OCT. This is the edema which is created after the laser, So this is how laser would appear on OCT. Now I think this is $1 million worth buying this machine. This is a patient who had horseshoe tear, myopic. Father has been operated, both had giant tear by me, highly myopic. Now, fortunately, they do not say, the optos do not say, but we could do OCT through that lesion at the ora serrata, and we realized that it's a enclosed dentate process and not the horseshoe tear, what clinically would have seen, Probably on depression also, we would not have seen this thing. Again, this is a subclinical detachment. This is a peripheral traction. You can beautifully demonstrate how it looks. Now, this is the same thing here. Now this is the patient I would like to show. This patient had buccal, then vitrectomy, gas-filled eye. There is a hole here. Now this was gas-filled eye. There was shallow detachment. As you see here, there is a shallow detachment. I did top-up filling of the gas, gave position, retina was attached, and you can see I could do laser there. However, this retina did not remain attached because there was a PVR. The beautiful place where I found it useful is this is we do pneumoretinopexy like Dr. Rajiv Muni. There was an inferior shallow detachment also. First day, retina superiorly settled. There was inferior fluid which increased when you see. Subsequent day, this was the fluid had increased here. So I'm just showing you comparative area. This is the area you'll see there was a new break here. So this was not miss break, but this was a new break, and we could do OCT, and it demonstrated the hole here, So this confirmed the finding of a break. Now, this is a patient of PVR. We could demonstrate a membrane here on OCT, and you'll see I'm showing you the surgery. Now here you don't see any definite membrane in the surgery, though the retina is a little stiff there, and you don't see any membrane. But since I had seen the membrane on OCT, we searched for it, we scratched the retina, and we could remove the membrane in the retina quite well. Now here see the posterior pole retina is stiff. Now I'm just taking the 23 ILM forceps and trying to scratch it, and then I've stained, and you will see that the membrane has come out well. So again, is it mandatory to have OCT? No, it's a useful adjunct in such cases. The advantage of this probably is that intraoperative OCT still you don't have swapsos, so this view will be better, and this is a membrane we could remove. Now this is the last case I would like to show. This is a bad diabetic detachment PDR, and here we did pre-op OCT at various levels, and we could decide the plane of surgery. Now I have kept the video here along with the photograph and OCT plane. So you can see the comparative area on the surgical video, what I have shown you OCT. Now when I'm pulling at the macula, near macula, the whole ERM is coming, whole posterior hyaloid with ERM is coming up, and we could get the nice plane there. You see now the entire posterior hyaloid is getting lifted, and if you see the OCT here, this is the area where I have been able to lift the plane of cleavage. So I think this is a wonderful tool if we can use it. This is a similar patient. I will not go through the video. Now, this is autofluorescence in a patient who had a macular VMT, and autofluorescence beautifully showed the new vessels here, and OCT done there showed that NVE here and vitreous condensation. So I would end my talk with this last slide, that you can do OCT from center to periphery and decide on thickness of the choroid, and this could be a research tool. And finally, I would end my talk with thanks to Dr. Srinivas Sadda, because 3 years back there was a lot of COVID and we could not have traveled outside country, and I was keen to buy, and his email made me buy this machine. Thank you, sir. Thank you for coming.
Thank you, Dr. Vatsal. Next, we'll have the expert on wide field imaging himself. Dr. Srinivas Sadda, or more popularly known as Vas amongst his friends and peers, is the director. He is now into artificial intelligence and image research at Doheny Institute and a professor of ophthalmology at the University of California, Los Angeles. He completed his training from Johns Hopkins University in Baltimore. His major research interests include automated retinal image analysis, retinal substructure assessment, advanced retinal imaging technologies, and vision restoration approaches. He served as a principal investigator for several trials, and he's led several international collaborative research programs as well. If I have to read his entire CV, we'll need the entire symposium, but I think I'll just let you do your talk. Over to you, please.
Okay, thanks, Chaitra, and thanks, Dr. Debashish. And thanks to NIKON-OPTOS for organizing this, or allowing us to have this symposium. And thank you all for finding your way here, because I know we started late, about an hour late, because of the previous session. So yeah, I've been very fortunate to be able to work on wide field imaging for more than 2 decades now. And it's pretty exciting to see these continued advances. And I'm going to talk about a couple of them. I'm going to follow up what Dr. Vatsal presented in his talk as well. These are my disclosures. And so I think everyone here recognizes how ultra-wide field imaging has revolutionized how we practice retina today. And I think that maybe a comparative innovation is to think about how fundus photos and then OCT in combination have proven over the years to be superior to even what we can achieve with slit lamp biomicroscopy. And I think you can say the same now now with the new innovations in ultra-wide field imaging, I think the same can be said about ophthalmoscopy. I want to credit Eduardo Medina and the group in Italy. They actually did a nice paper where they actually directly compared getting an ultra-wide field image compared to ophthalmoscopy with scleral depression, and they actually found a very good correspondence. And because of the fact that ultra-wide field imaging gives you a static view, they actually suggested this should be our first-line diagnostic. Now, even when I read this paper, I've always wondered, can you really get everything you can get with what you can achieve with dynamic indentation? I think it's very helpful with dynamic indentation ophthalmoscopy to try to see vitreous traction. This is where I very much agree with Dr. Watzel that having peripheral OCT, I think, actually does get us to that point now, because now, not only do you get the entire image, you can actually study those areas to see if there's traction. And so I would tend to agree with the conclusions of this paper now, as I'll highlight. I think one big area where this has been very helpful is in medical record documentation as well. Before, we used to spend a lot of time making these annotated fundus images, but now it's much better, obviously, to just simply get an ultra-wide field image and annotate it. That's actually, I think, a much better way, because the adage is a picture is worth 1,000 words. So why do you want to make these very detailed annotations or detailed drawings? I think you can save a lot of time by simply annotating these images. The one caveat, though, is that historically, these images that are obtained through the OPTOS system are red-green images. They don't have a blue wavelength, so it's kind of a pseudo-color of sorts. And that's what the latest innovation really that I wanted to focus on today is that now we have the new California RGB device where you've added the blue laser, and then you can get a color appearance that is a more natural appearing color that more reflects what all of us see when we actually examine the patient. And again, of course, you can get just with a single snap with an OPTOS, you can cover a large proportion of the retina, but you can augment this further even with steering where now you can consistently get over 90% of the retina and actually visualize the ora serrata in more than one quadrant. There have been some small studies already that have started to compare the red-green versus the red-green-blue image and have shown equivalence. And I will say that sometimes one of the points I wanted to make was that even though they seem to be equivalent, there are different types of conditions or different features where one may shine over the other. Now, you don't have to choose, because when you get the image, you get both for free, right? You get the red-green-blue, but the red-green is also obtained or available to you. And I just wanted to highlight, it's interesting now that we've been able to go back and compare these, that we recognize that actually all of the information is there in the RG image. It's just that some of them are more prominent or appear more easily when you add the blue laser. There's certain features that are just simply brought out. So I guess one of the themes of this presentation is going to be that they both have their advantages, believe it or not, and that actually not having the blue can sometimes help you see certain things, and I'll try to illustrate that as well. But again, the real, I think, big advantage of having this RGB now is that what you capture on the picture very much reflects what you saw when you looked into the patient's eye, and I do think that makes a difference. Okay, so in particular, I think that whitish lesions actually now really look white. I really liked Dr. Watzel's presentation because he highlighted some of these areas of white without pressure may actually be harboring areas of schisis as well. I think that's the case. Some of them, I think, really are truly areas of vitreous adherence that is truly white without pressure. But again, you can see that you lose that kind of greenish overcast. Right now, actually, whitish lesions or whitish structures appear white. Here's another example of a patient with myelinated nerve fiber. And again, you can see that the whitish, the true natural whitish appearance of these lesions becomes very well apparent. Here's another patient who I've been treating for many years, has developed areas of subretinal fibrosis, and you can see again the more natural rendering of the whitish color of the fibrosis using RGB imaging. And also for patients with retinal degenerations and other types of pigmentary alterations, sometimes these areas of age atrophy and depigmentation can be overwhelmed by the greenish hue. It's hard to delineate or understand them. And again, you can see a more natural fundus appearance. Another patient with a retinal degeneration, again highlighting the areas of deep pigmentation which appear more natural. Here's another patient with retinitis pigmentosa, seen pigmento. Again, you can see a pretty striking difference by adding the blue laser in this case. Here's a patient of mine with Sorsby's fundus dystrophy. Again, you can appreciate the coloration of the deposits, I think, more precisely. Here's a patient with pseudoxanthoma elasticum and angioid streaks. Again, the streaks, I think, in terms of their reddish coloration is more easier to appreciate without the overcast there. It's a little. This was meant to also illustrate this patient does have some peau d'orange as well. Again, retinoschisis, I think, is something that peripheral OCT, I'll highlight, has made a big difference. This patient, you can actually see the margin of the schisis perhaps a bit more easily with the RGB image. I will say the blue laser does give you better visualization of more superficial retinal details, and I think for areas of schisis and the like, it's not surprising that could be of some help. Also seeing these, we've been studying a variety of different types of lattice degeneration using this technology. And again, we recognize many of these lattice lesions can have this whitish sort of appearance related to some alterations of the vessels and the like going over the lattice lesion, and that's easier to appreciate using this kind of true color imaging. Here's a patient with a rhabdomatosis detachment from Dave Brown, very similar to the case that Dr. Watzel showed. Nice thing with these Optos systems is very easy to capture these images, right? Even in patients who've immediately had some type of procedure obtained. Diabetic retinopathy, we already know there have been very nice studies that have shown that Optos, the pseudocolor imaging, Dr. Rajiv has been involved in many of those, can do a good job of grading the severity of the retinopathy. And so I don't think it's because that we were missing those lesions. We see them just fine. It's just that everything, again, in terms of the coloration is rendered in the way that we might expect. More examples of patients with diabetic retinopathy. One thing I will highlight again is when you have fibrous proliferation in these patients, again, you can see the difference in the coloration, right? Like white looks white, which I think is again very helpful for being able to reflect exactly what we see in the patient's eye is reflected now in the image that we obtain. So I do think that there is significant value of adding the blue to the ultra-wide field platform. Another patient with pathologic myopia, you can see the whitish coloration, so the bare sclera in the areas of patchy atrophy in this case. And here's an example of a patient with Azure who you can see the areas of depigmentation atrophy again more easily with the blue laser added. Now, one area where I think very clearly there's an advantage of having the addition of the blue laser is in patients with reticular pseudodrusen. This patient has extensive reticular pseudodrusen. You may recall that these lesions were first identified by Gabriel Koskas and Giselle Subran on using blue reflectance imaging. So it's not surprising that adding the blue laser will allow us to see these lesions more easily. An example of a patient with chirpy. And I wanted to highlight these pigmented lesions because here you can see a patient with a choroidal nevus. And I think you can all appreciate that the nevus and its borders are actually easier to see on the RG image. And that's a very consistent sort of observation that these deeper lesions, the blue laser is not so helpful, and maybe actually that additional information makes it harder to detect. Now, of course, this probably reflects more obviously what we see, the RGB image, when I examine the patient. Sometimes I've been struck by, I've examined this patient, the nevus was barely visible, and yet I obtained the Optos image and the nevus stands out. Now you can see why. Again, because the lack of the blue actually makes it stand out a bit. Here's another example of another patient with a more suspicious type of nevus. Here are more examples of nevi again. You can see that they're very well seen on the RG image. Here's a patient with a melanoma. Again, I would argue that the borders are easier to delineate without the blue laser, but this is another patient that was treated, and you can see the areas of atrophy following the application of the plaque. Patient with a choroidal hemangioma. Again, it's almost difficult to delineate the borders of the lesion. I felt it was difficult when I was trying to examine the patient. Actually, it's easier on the red-green image. So really my point of that I want to make here is that you don't lose having the red-green. You get both. You get the red-green-blue as well as the red-green, and I want to highlight that they have different benefits. I will say this is a patient with a MET and metastatic lesion, and the metastatic lesions oftentimes have a whitish kind of appearance, and you can see the whitish appearance is more easily and accurately displayed using the RGB image. And a patient with retinoblastoma, again, if you really want to have a nice illustration of the difference in coloration and something that truly is white, you can see it looks chalky white on the RGB image, just highlighting the accurate color rendition. Now, peripheral OCT was the other major big advance, and I think Dr. Vatzel did a great job of describing this. And Chaitra already went through the definitions of that when we tried to standardize the definitions for different zones of the fundus as well as the different regions. And I just want to say the far periphery is the region of the retina anterior to the vortex vein ampulla. And what I wanted to highlight is that wide field OCT is not the same as far peripheral OCT, right? Wide field OCT just talks about how big the scan is. Over 20 millimeters, many people would say that's going to be a wide field OCT, but that's not a peripheral OCT. Peripheral OCT means you're actually imaging the far periphery. So it's an example. You can do wide field OCT with the Silverstone, obviously, but we're talking about actually doing peripheral OCT imaging and how that can help us. And I thought I'll also show some case examples. Here's a patient, again, this is the wide field OCT, if you will, of this patient with gyrate atrophy. And I've always been curious, these little areas that you see out in the periphery, are there areas of preservation? And we've been able to study them, right? We can get an OCT. Wherever you can get the Optomap, you can get an OCT. So you can pass an OCT scan through that area, and you can see, in fact, there is no outer retinal preservation of that area. All these areas are involved in these patients' eye. We've been using this extensively to track and monitor tumors. As a patient who treated with retinoblastoma, there's some residual regressed tumor in the bed of the lesion we've been able to follow over the years because we can scan. Again, you can obtain a volume anywhere you want in the fundus. Here's a patient with a preserved paraarterial RPE, a variant of retinitis pigmentosa, but these patients can sometimes have astrocytic lesions. Like this patient has a very vascular lesion, I might add, that we've been able to track using peripheral OCT imaging. Again, sometimes this is a pretty obviously a nevus that you can appreciate here, but sometimes we get pigmented lesions where we're not so sure, and sometimes they're so small that it's difficult to measure with ultrasound. This we found OCT to be quite valuable. This patient obviously has a very typical appearance of a nevus on OCT imaging. Again, we can get the scan wherever we want, and you can see that there are drusen overlying it as well. Here's a patient that was referred to me by the oncologist because this patient was known to have CNS lymphoma. They had new vitreous floaters. They had no macular findings, but you can see all of the abnormalities in the periphery, and we were already suspicious this likely lymphoma. But it was nice to be able to pass the OCT through there, and you'll appreciate that these are actually deposits that are located in the sub-RPE space where you would expect to see in the setting of vitreoretinal lymphoma. Again, Dr. Vatzel did a brilliant job of kind of talking about this, but we've used this as a nice tool to track and follow schisis because you can map exactly where the schisis begins and ends. I can tell you that there are many patients with schisis which were difficult to appreciate clinically, that you start to pick up and you start to wonder about your examination then. But in any event, this patient actually had such massive schisis, they even had an outer retinal hole, but we were able to delineate by mapping out the fundus. Now, what I wish we could do is we could just map the entire fundus with OCT. You can't quite do that yet, but you could if you actually took the time to do all of these kinds of scans. Okay, so I'm going to skip forward in the interest of time to point out that we've seen many patients who, again, it's sometimes difficult to make this distinction between a schisis or schisis associated with attachment. Many of these patients get laser barricade, and some of them probably unnecessarily. There are many patients we've seen who have schisis and not who thought by the referring doctor they thought that they had a detachment, but then in fact didn't have a detachment. It's just another example of such a patient. This is a patient. This is actually post-treatment. You can see a patient with dialysis that was treated with a laser in this case, and really want to highlight how you can appreciate the vitreous attachments in this case. More examples of patients with lattice generation. I also agree this is a beautiful tool to study lattice, and you start to understand understand the vitreous relationships here, and we'll hopefully have a paper coming out soon on this topic. And again, other lesions, which, I always thought, like, is that really a cystic tuft? Well, it actually is, because you can pass the OCT through and you see that these are in fact cystic tufts. I think the biggest benefit of having peripheral OCT is recognizing vitreoretinal traction. I mean, I can't tell you how many times there are lesions that we've seen where I could not appreciate that there was vitreous traction that we could see quite easily. This patient we would have treated anyways, who had an operculated hole, but this patient was symptomatic, so I was going to laser them anyways. But there are many patients where we see this, right? So there's actually significant traction on this operculated hole, and this might redefine how we approach which patients we're going to choose to laser. So identifying vitreoretinal traction, huge beneficial aspect of having peripheral OCT. Here's a patient who doesn't actually have a break, but had areas of tractional elevation in the periphery. We scanned through this densely, and we could not actually find an actual hole. So many examples of that. I can go on and on. A lot of patients with operculated holes who still have traction. There's patients with operculated holes who don't have traction. I think those patients probably need to be treated differentially, but that'll have to be established with proper prospective studies coming up. So I want to say that there are some studies that have been done to start to look at the utility of this. Dr. Vatsal and myself showed you a number of cases, but I think systematic study is going to be useful to define exactly how we use this, although to me it's pretty apparent. But Nitin Chaudhary in Toronto, Canada, had done a very nice study where he actually found that by obtaining peripheral OCT, it changed his decision-making in a large proportion of cases, which really highlights this is not just it's fun to have. This is actually, I think, a very potent clinical tool. Example of a patient where he didn't appreciate that there was traction. This patient has evidence of peripheral traction. And again, as I said, you can image out to the periphery here. This is imaging out at the ora serrata. You can see the vitreous base in this particular patient. We've already talked about a number of different retinal detachment cases, so I won't belabor that point. You can actually even try to do OCT in these areas of detached and elevated retina, which is pretty interesting. And that's if you want to appreciate what the vitreous relationships are before you get into the operating room, I think that potentially could be useful. And this is a patient who actually had both a macular hole and a peripheral hole, as it turned out. Another example of an operculated hole from Nitin's study. So to summarize, I think we're pretty fortunate. There's been a lot of progress in ultra-wide-field imaging over the past 2 decades. I do think that the addition of the blue laser is not a small deal. I think it's a big deal because it does provide us, as I showed you with many case examples, an accurate and faithful rendering of the color of the fundus. So it really documents what we actually saw when we saw the patient's eye, and I showed you how it's helpful in whitish lesions in particular. So you can imagine in the setting of certain tumors and inflammatory diseases, that's going to be especially valuable. I think peripheral OCT really adds to this armamentarium. I think it really brings us to that point. What macular OCT did to slit lamp biomicroscopy, I imagine this is going to do to ophthalmoscopy. Thanks very much.
The RGB, which is the new innovation that we have from Optos, but also the peripheral OCT. You added a lot more to Dr. Vatsal's talk. Can I have a show of hands as to how many of you will actually have a Daytona or a California? How many of you? Oh, that's quite a bit. And how many of you love it? Okay. Now, how many of y'all, if it was more affordable, would buy it? Maybe more of them. Yes. So I guess that the take home here is that it's a fantastic tool, and all of us really, it can add to us. Now, I will just have a quick panel discussion. In the meanwhile, can I have the screen? Just after the panel discussion, we'll have a quiz on some of the things that we just saw now. It'll take a couple of,
I have one question.
Yes, during the panel. Yes, please go ahead.
I had 2, 3. The RGB is really, really impressive. My only thing, one of the way we use Optos more is those patients who have cataract. We tend to take the images and we get a very good quality. Will that advantage become less if we use RGB?
That's a great question, and there's no question the blue light is going to be more scattering with media opacity, but that's the advantage, right? You get both, so you don't lose it. You still get your RG, and I think that you're correct. We haven't done enough studies to see how much the quality is degraded specifically with cataract by adding the blue. But as I said, there's nothing lost. But I agree with you that I would expect that you're going to get more issues in the setting of media pass.
And does it have any concern of increased cataract because you are exposing more blue light now?
I would doubt it. I think that you're talking about blue light and over a large area now, and the detector on the device is very efficient. So it's actually pretty comfortable for patients, surprisingly, compared to some of the other devices that do this kind of imaging. So we haven't gotten too many complaints about that.
Just last about blue thing, will it the autofluorescence mode? It will not be, because will the quality of autofluorescence improve or worsen by using this?
So actually, most of our work so far with ultra-wide field imaging has been in green autofluorescence. I actually am a big believer in green autofluorescence because I think with autofluorescence, then the light intensity is a bit greater. And you can do blue autofluorescence. We're just getting the blue turned on our California RGB now because it can do blue autofluorescence in addition to green. But all of our work so far has been on green. But personally, I think for autofluorescence imaging, I prefer green when available, because for the reasons that you were saying, Rajiv, that I think that it may be safer.
I think the peripheral OCT is really a boon.
Yes.
And many times, we have been advocate Shankanetralaya fellows, they all put a belt buckle, assuming that relieves a vitreous traction. I think it would be really worth seeing that whether putting a belt buckle would really relieve a vitreous traction.
Absolutely.
Yeah, I think again, I don't usually use the word transformative very often, but I think the peripheral OCT is transformative because it highlights all the things that we were missing or we thought was the case. Or maybe I just need to get better at examining vitreous relationships using ophthalmoscopy or indentation ophthalmoscopy alone.
I just had a quick question from Dr. Debashish. They have quite a number of equipment, and most would wonder if it is difficult to handle them. What's your wear and tear, since you use it in a large number of patients with over 100?
Chaitra, got your question. So, sorry. We've been having 3 OCTs for the
3
from 12 and then from 14, so that's about 10 years.
Okay.
We don't have, the helium gas was required for the DX 200. That used to cost 5 lakhs per year, I think. But with the Daytonas, you just have to be careful with the mirror. That, the eye drops, the teardrops don't drop in there. And honestly, no maintenance really.
Okay.
Yeah.
Great. Dr. Vatsal, have you stopped using your previous OCTs even for your macula, or do you use this OCT only for your peripheral?
See, the thing is that in high myopic eyes, this gives the Silverstone gives a good view of the posterior pole. But since this is 23 mm, you will not get the finer details what you will get
Resolution
on regular OCT. So I used to do it, but now another way of doing is that probably you reduce the beam to 6 mm or something, you will still get the finer details. But otherwise, as I told you, for fine details of macula, probably I still use my Nidex sometimes.
Yeah, I just want to ask Dr. Jalali, ma'am, do you have, what challenges do you face when imaging the tiny kids? Because they are mostly supine patients. So are you using the flying baby, or what position do you use to image them on Optos?
So first of all, I want to acknowledge that I have not done any of these imagings. The heroine is here, Sushma, who does all these cases. So the practical tips she will tell. But I want to just highlight from the work that we've done on the babies, which of course, as you rightly said, Dr. Patel was the first one who showed us the path, and then we took it up, that many of the machines, they're not made for babies, unfortunately. And only 23 million babies are born in our country, 10% of whom have silent disorders, including Coats and FEBR and so many diseases. But we're not able to reach them because these machines are not meant for babies, unfortunately. They should have been. So now we've brought this machine to the babies by the flying baby position, The advantage of this, although we have Forus camera, we have Red Cam and all these, the pediatric cameras, the advantage is in the OPD, it just takes few microseconds. Yeah. So there's no, it's a non-touch technique. And really we've not faced any major issue because we've been able to image all of them. But yes, there are some artifacts which we have to look after. We have to have little training of the technicians. And of course, if they're sick babies and they're in the nursery, so we're not able to take the machine to the nursery. So yes, we hope someday these things will also come into the field of Dr. Sadda and his team, and they will, make our life easier. And we can then really look at so much of pathology which we are missing currently in these babies just because we don't have the same imaging which we have for the adults. The OCT also for the babies now we've been using, we published also, it's picking up, PAM lesions, it's picking up inner-retinal ischemia, and these are biomarkers for knowing whether anti-VEGF will work or not. And there's no other biomarker for that. So I think the more we are able to access these technologies for our pediatric patients, we'll see much more and know more than what we've been doing so far.
That's very, very important, and I think Madam is going to tell us a little bit more just before the book release. So if all of you all have scanned the QR code, we'll go ahead with the quiz. It's a very quick quiz, so you'll just have to choose the right answer. Here you go. And there are some attractive prizes, so the top 3 will get some. It should be visible on your screen, on your phones. The faster you answer, the more points you would score. Yes, it's also a time-based thing. So Rajiv. Yes, Rajiv is at 7. Come on. A lot of these questions were just covered during the talks itself, so they're just a revision. Natasha's going strong. They can come up and we'll do that. I want to apologize to the people from the next session. I think the scientific committee is aware that the hall, we got it only an hour late. So we're trying to complete it as soon as possible. We're at the last. We have just one quick talk from ma'am and the release of the book. Okay, I think we're done. Any more questions? I think we'll end it now. We've given everyone enough time. I hope you'll have all completed it. So, no, this can't happen. Okay, so can we have the winners quickly on stage? Is Dr. Supriya here? Dr. Supriya? Dr. Archana and Dr. Bridge. Come quickly. I request Dr. Supriya, Vij and Archana. Thank you. I'll quickly now introduce Dr. Subhadra. All of you know her for her fantastic work that she's doing with our little kids. She's achieved so much over the last few decades. She's the network director quality at LVPI, best known for her work on ROP. She's also the director of the Newborn Eye Health Alliance at LVP, and which provides neonatal care. I think the most important contribution that she has done is she has created little Subhadra Jalalis across the country who share her enthusiasm to treat the little ones. Over to you, ma'am.
इसको नीचे रखो ना मुझे मेरा फेस है. Okay, so here we go. So what I wanted to highlight is that there's no better joy for a mentor to see that their students do better than them. And this is all work of Sushma, who's here, and she has taken the lead to use this machine to image the babies. And this atlas is a lot of hard work for over 3 years, taking the babies, taking the images, working with the technicians. Basically, this atlas is giving us a lot of information about what we actually see in the ROP, how the machine can be used by anybody who has the machine for imaging babies. And it is giving us a lot of information about ROP, but also about some additional other disorders. You can follow up these patients. You can actually see how the disease can be measured, how the parents can be educated about the disease, how your staff can be educated. And then there are other, a whole chapter on the artifacts that would happen and how you can avoid those artifacts. This work is also published in multiple ways, both in terms of comparing the Optos imaging to the indirect ophthalmoscopy and what's the things that we miss or what are the things we pick up. It's also been published along with the OCT now by our colleague Dr. Akash. So I would encourage all of you to please use this atlas to educate your parents, your staff, your neonatologists, your trainees, and to learn yourself what we can do. Many of us don't have access to the pediatric cameras because we may be being solo practitioners, or an occasional patient comes to us, and this imaging can be done in children or babies who are about 2.5 to 3 kg. When they become bigger, then it's little difficult to do. But at least in the early phases where it's more critical to image these eyes, it really works. So with that, I would just request Dr. Sada to please take up the book and show it.
So thanks to Optos Nikon for this opportunity. I think we had a good symposium where we spoke about the benefits of the new RGB, how different it looks in little true color, and the peripheral OCT as well. Thanks to the entire panel. We can conclude the session now. Thank you.
And thanks to the next session, because we got the session 1 hour late. We made up some time. I hope you also make up some time. Thank you.